Hello, this is Rick Wiggins from the University of Utah, and today we're going to talk about cranial nerves 7 and 8. I have nothing significant to disclose about the nerves. So we're going to look at the important anatomy that's around cranial nerves 7 and 8, and we'll discuss a couple of the more common pathologies and look at those imaging characteristics of those nerves themselves. So for each of those, we'll look at the anatomy of the nerve, and then we'll look at some of the more common pathologies that happen to that nerve. So first we'll do the facial nerve. So the facial nerve has a lot of segments, especially intertemporal, when you think about through the CP angle cistern. So there's a cisternal segment, a part in the interauditory canal, a canalicular segment, a labyrinthine segment, an anterior genu, then a tympanic segment, and then a descending or mastoid segment that goes down inferiorly. So the facial nerve is very complicated, and it's complicated on functions. It has several different functions. We think about it mostly being involved in branchial motor with the voluntary and involuntary muscles of facial expression. But there's also some visceral motor that we think about going to the salivary glands, and special sensory taste going to the anterior 2/3 of the tongue. So since there's three main functions, it makes sense that there's three main nuclei that involve the seventh nerve. So in an axial graphic here at the level of the fourth ventricle, under the facial colliculi, those bumps on the front of the fourth, under that is 6. The fibers of 6 come out anteriorly at the pontomedullary junction. The motor nucleus of 7 is actually anterior and lateral to 6, and those fibers do kind of a strange thing. They wrap around 6, and then they come out the bottom of the pons, and they pass in between the superior salivatory nucleus, so that's that parasympathetic innervation to the salivary tissue, and the solitary nucleus or solitary tract, so that's that taste to the anterior 2/3 of the tongue. So here's a nice graphic. If we think about where the pons hits the medulla, we see 6 coming out anteriorly. 7 and 8 actually come out here at the bottom of the pons, but we think about them coming out the inferior pons and going over to the CP angle cistern and then to the interauditory canal. And in the IAC, they divide up. So the seventh nerve is on top, cochlear nerve is on bottom, and the superior and the inferior vestibular nerves are in back. Now the facial nerve itself, here's a graphic dividing up the facial nerve into functions. So yellow here is the motor, so the voluntary and involuntary muscles of facial expression. In green here, we see those parasympathetic innervation to the lacrimal gland along the greater superficial petrosal, and there's some parasympathetic as well as special sensory taste that goes along with the chorda tympani anteriorly to the anterior 2/3 of the tongue. Now, we think about the facial nerve dividing up the parotid into a superficial and a deep lobe. There aren't really lobes that are separate. It's just that the facial nerve goes through the parotid itself. And that's where it splits in the pes anserinus, the goose's foot, all those branches, temporal, zygomatic, buccal, mandibular, cervical, and occipital, that go out through the face. The descending or mastoid segment has two little branches, the stapedius and the chorda tympani, as it comes off at that location. So on imaging, on MR, we'll see the cisternal and the canalicular segments best of the interauditory canal. And if we do oblique sections that are perpendicular to the IAC, we'll see the facial nerve and the vestibular cochlear nerve. We often see these flow voids with aica loops that may extend into the IAC. At the porus acousticus, the opening of the IAC, we see the facial nerve separate than the vestibular cochlear. And at the midpoint of the IAC, we see seventh nerve here anterior, the cochlear nerve anteriorly and inferiorly, and the combined superior and the inferior vestibular nerve. So this is the cerebellum, so I know that's posteriorly. So at the midpoint of the IAC, we can remember 7 up and coch down. So the seventh nerve is in front on top, and the cochlear nerve is on front and back. Then the seventh nerve is going to go over the labyrinthine segment, and the cochlear nerve goes to the modiolus in the middle of the cochlea, while the superior and the inferior vestibular nerves go over towards the vestibule. So on MR, we see those segments best. On CT, we'll see the intraosseous segments. So we see that little labyrinthine segment going up to the anterior genu. Then we see our tympanic segment going under the lateral semicircular canal. Then we have a posterior genu, and then a descending or mastoid segment that goes down inferiorly through the mastoid air cells. If we look closely near the level of the anterior and the posterior crura of the stapes, that's where the little stapedius muscle comes off, that branch from the descending or mastoid segment. And if we think about where that tympanic segment is and we do an oblique section through it, we can see that posterior genu and then the descending or mastoid segment going down. So here's another graphic showing again those different functions. So we have a labyrinthine segment, a tympanic, and then a mastoid or descending segment. The greater superficial petrosal nerve comes off the anterior genu, and from that descending or mastoid segment, you have the little stapedius nerve, and you have the chorda tympani that drapes through the middle ear cavity itself. So if we do one of those oblique reconstructions, we can sometimes see that chorda tympani coming off the descending or mastoid segment. So the little stapedius branch of the chorda tympani that makes the sharp 180-degree turn to go up. So if you ever want to explain the facial nerve, if you take a paper clip, we can unfold it to be the facial nerve and that complex intertemporal course. So if we think about our left temporal bone in the axial section, we're going to have a little IAC canalicular segment. Then we have a labyrinthine segment to the anterior genu, then a tympanic segment going back under the lateral semicircular canal, and a descending or mastoid segment going down inferiorly. So that is your facial nerve left tympanic. So what pathology happens to that anatomy? Well, a pseudomass or pseudolesion is just normal enhancement. It's normal to have some enhancement around the genicular ganglion, then the tympanic segment, then the labyrinthine segment. About 2/3 of the cases you may see avid enhancement on, and in about 2/3 of those it'll be asymmetric. One side may not look like the other. Now, if we do have trauma here, you might have a fracture of the temporal bone, and here we see a fracture going right through that labyrinthine segment anteriorly. But on MRI, the enhancement of the facial nerve can be very confusing, and we have a lot of different pathologies that may happen here. These are important to differentiate. First, we have a herpetic or a Bell's palsy. That's going to be clinically an idiopathic acute onset of lower motor neuron paralysis of the face. On CT, it's going to be normal, but on MR, we have asymmetric diffuse and tense enhancement. So here's an axial CT and the correlating post-contrasted MR. So we see the genicular ganglion, the greater superficial petrosal nerve that comes off to form the pterygoid or vidia nerve going forward. And here on the correlating post-contrasted MR, we see avid enhancement laterally within the IC, the labyrinthine segment, the tympanic segment, and the greater superficial petrosal all avidly enhancing, in this case of a herpetic or a Bell's palsy. Here's another case. Here's an axial post-contrasted MR. We see avid enhancement all the way along that course and avid enhancement along the descending or mastoid segment consistent with a herpetic or a Bell's palsy. Now, we can get schwannomas anywhere we have nerves, but specifically along the facial nerve, not only clinically, but also imaging, that's going to depend on the location involved with the nerve itself. So which segment is involved, we may see very different appearances on our CT and our MRI studies. And we know that frequently around the skull base, we end up doing both CT and MRI. Now, if we have a case of an enhancing lesion in the internal auditory canal, we're going to think about a vestibular schwannoma. And it's very important here to look for a possible tail of enhancement and enlargement along the labyrinthine segment of the facial nerve, because we want to differentiate a vestibular schwannoma from a facial nerve schwannoma. This was a case that looked a lot like a vestibular schwannoma, partially involving the CP angle cistern and partially involving the internal auditory canal. But when they did the CT, they saw widening of the labyrinthine segment and avid enhancement after contrast on the post-contrasted MR going to the genicular ganglion. So this is actually a facial nerve schwannoma, not a vestibular schwannoma in that case. Now, that labyrinthine segment has dense bone on both sides around it. So when we think about the labyrinthine facial nerve schwannoma, that has kind of a classic radiologic appearance of a schwannoma with smooth scalloped borders on the walls. So if we think about in this graphic a lesion that is extending along that labyrinthine segment of the facial nerve, if we do a CT and an MR, we may see enlargement of the labyrinthine segment, enlargement of the genicular ganglion, and avid enhancement all the way along that course with a facial nerve schwannoma of the labyrinthine segment. Now, next we have that genicular ganglion or anterior genu. So we may see a small bulbous lesion where the greater superficial petrosal nerve is coming off at the anterior genu of the facial nerve. So here's an axial CT and the correlating T1 MRI without contrast. We see a soft tissue mass at that location, and we see a significant enlargement of the anterior genu where the geniculate fossa is. So that's a good appearance for a geniculate fossa facial nerve schwannoma. So the next segment of the facial nerve is the tympanic segment. Here we lack the dense bony boundaries of the labyrinthine segment. So a mass at this location may pedunculate down into the middle ear at that location. So on a coronal CT, we're here at the level of the duck head. So the head of the duck is the vestibule, beak is the lateral semicircular canal, neck is the basal turn of the cochlea. That's where the oval window is. Here we see the tympanic segment that should be under the beak, but we've lost the inferior border and we have a mass going down into the middle ear cavity. So that's a good appearance for facial nerve schwannoma. On the axial correlating CT, we see that soft tissue mass that kind of extends along the tympanic segment of the facial nerve, and it's pushing the ossicles out laterally. We differentiate that from a cholesteatoma, where we're destroying the ossicles. Here we have ossicular destruction, but here the ossicles are just pushed out laterally with the schwannoma. So the cholesteatoma, we look for osseous destruction, whereas the schwannoma may just displace the ossicles. So next we have the descending or mastoid segment. So here we have all these air cells that are around the descending mastoid segment, and as the schwannoma enlarges from the mastoid segment, it may have a lumpy, bumpy, or bossylated appearance on the outside. So here's an axial CT on top. Here's the normal small descending mastoid segment, and here's a large mass on the other side that's replacing that segment. And when we give contrast on the correlating post-contrasted MR, we see avid enhancement around that area. So as you can imagine, this might extend into the external auditory canal. Here's another case where we had a more bulbous portion extending from the descending mastoid segment into the EAC with avid enhancement after contrast. Now we want to differentiate a schwannoma from a venous vascular malformation of the facial nerve. What used to be called a facial nerve hemangioma, but these lesions actually have osteoblastic activity, and it may have a very invasive appearance on MR. So here's a graphic showing a lesion there at the anterior genu, and we think about that lesion with these little osseous flecks that are being laid down. So on the axial CT and the correlating post-contrasted MR, we see enlargement of the genicular ganglion with this strange honeycomb spiculated bone and avid enhancement. So those osseous changes are very different with a facial nerve venous vascular malformation than what we saw with the schwannoma. Now, we also want to differentiate that pathology from perineural tumor spread. Often with minor salivary gland tumors, especially adenoid cystic carcinoma, we think about perineural tumor spread that may go from the parotid up into that descending mastoid segment. So in this graphic, we have a pathology in the parotid that's going up that descending mastoid segment of the facial nerve. It may go distal, but it may go proximal along the nerve. So then we look for a mass in the parotid on this coronal post-contrasted MR with avid enhancement going up the descending or mastoid segment. And we also see abnormal enhancement along not only the labyrinthine segment, but also in the interauditory canal, consistent with perineural tumor spread from this parotid lesion. Now, if the patient instead had a vesicular rash on the ear, we might think about herpes zoster oticus or Ramsay-Hunt syndrome. And this has more nodular enhancement that may extend along the facial nerve in its entire course and include abnormal enhancement in the internal auditory canal. We should not see any enhancement along the cisternal segments of cranial nerves. So next is the eighth nerve, the vestibular cochlear nerve. So this nerve is responsible for hearing and balance. So the cochlea, hearing, and the vestibule and superior and the semicircular canals are responsible for our balance. And we have these complicated inner ear structures that are around the facial nerve. Here's the labyrinthine segment coming towards us and the tympanic segment going back, and that goes around the inner ear structures in the otic capsule, densest bone in the body around those structures. So if we think of all these chambers, we have these fluid collections that are within them. The cochlea, the vestibule, and the semicircular canal are all connected where this perilymph and endolymph is going through those chambers, connecting them. So if we think about just the fluid, we realize that the vestibule is made up of two parts, the utricle and the saccule, and each of the semicircular canals has its own swelling or ampulla that each get a nerve. Now, if we look closely at the cochlea and we think about hearing, The cochlea is divided up in these different segments if we think about a cross section through the cochlear canals. So we have the scala tympani, the scala vestibuli, and the scala media, where the organ of Corti, or the basilar membrane, is, with its 1 inner and 3 outer rows of hair cells. Those hair cells go to the spiral ganglia that populate the modiolus, and the spiral ganglia all coalesce to form the cochlear nerve. So on this graphic, we see all those spiral ganglia in the modiolus. That's the bow tie in the middle of the cochlea, and they all connect to form the cochlear nerve that goes through the cochlear nerve canal into the internal auditory canal. And we're almost to the point where we can think about these different chambers in the cochlea itself. So on this cross section through the cochlea, you see that scala tympani, scala vestibuli, and scala media. If you were to take all those channels and kind of unroll them, you would have one long structure. So we think about perilymph on the outside and endolymph on the inside. So the scala media is on the inside, scala vestibuli on top, and scala tympani on bottom. So the oval window connects to the scala vestibuli, and the round window connects to the scala tympani. So the stapes is going to connect here to the oval window. So the perilymph that goes through the scala vestibuli is contiguous at the cochlear apex with the scalar tympani on the other side. So that fluid in those chambers is actually contiguous with perilymph on the outside and endolymph in the middle. So perilymph is a little bit more like CSF in terms of sodium and potassium concentration, and the endolymph in scala media is a little more like intracellular fluid in terms of sodium and potassium concentration. So those nerves all coalesce from the cochlea, and they go over to the midbrain and then cross over to the other side to go up to the auditory cortex. And it's very similar actually with the vestibular nerves that go to their nuclei within the midbrain itself for balance. So we have hearing with the cochlea, and we have balance with the vestibule and the semicircular canals. So on CT, we see that otic capsule very nicely. And we want to be sure we have a very wide window here when we're doing temporal bone studies. We want a window something like 4,400 or 5,500 so that we see these subtle osseous changes to the otic capsule, densest bone in the body, around the cochlea and the vestibule. And we see here the vestibule nicely in the lateral semicircular canal at that level where we think about our balance syndrome. We can compare the CT with the MRI. We want to see a nice CSF-like bright signal within both the cochlea and the vestibule, and those nerves, as we think about the facial nerve and the vestibular cochlear nerve, going through both the CP angle cistern and the internal auditory canal. And again, those nerves are going over those structures. So the utricle and the saccule get a nerve, and then each of those ampulla, the swelling of the semicircular canal, each get a nerve. So the superior and the inferior vestibular nerve divide up into those structures. And they all coalesce to their nuclei in the midbrain, where we think about hearing and balance being centered. Now, if we look closely, we can sometimes see these other channels. There's a little superior vestibular channel where the 3 branches of the superior vestibular nerve go. There's a utricular nerve, a lateral semicircular canal ampullary nerve, and a superior semicircular canal ampullary nerve that all go through the superior vestibular canal. There's a small canal more inferiorly, so that's the inferior vestibular canal. That just holds the little saccular nerve. And there's a little canal in the back that's kind of by itself, so that's the cingular nerve, and that has the nerve to the posterior semicircular canal ampullary nerve that goes through there. Now, when we're evaluating the CP angle and the IAC, we think about post-contrasted T1 kind of being the gold standard to evaluate those areas. But more and more frequently, if I just have an older patient with hearing loss, I do a high-resolution CSF bright or T2 weighted sequence to evaluate. And if I have a lesion there, I think about the fundal cap, how much CSF I see lateral to the lesion, and I try to figure out the nerve if I think there's a vestibular schwannoma, and I think about the cochlear nerve canal to see if that's involved, as well as the cochlea and the vestibule. Do I still have CSF-like a bright signal within those structures, or is it replaced with a filling defect that might be a schwannoma? Now, our imaging has gotten better over years. Here's a patient who had bilateral Iac enhancing lesions at 5 millimeters. When we got 3 millimeters, thinner cuts, we saw a little unusual appearance on the side. If we zoom in over there, we see it looks very unusual for a schwannoma, But as our imaging got better with 1 millimeter thin sections, we see there were actually 2 schwannomas on 2 different nerves on that side. So whether you're doing a KISS or a SPACE, a T2-FSE or a FIESTA, whatever sequence you're doing, we try to evaluate these nerves when we're thinking about the pathologies that may involve the 8th nerve, the cochlear vestibular nerve. So we have some common things, usually vestibular schwannomas, and some less common. So vestibular schwannoma is thought to be by far and away the most common lesion of the CP angle in the IAC, especially in a patient presenting with hearing loss. There are a bunch of rare lesions that might happen within the CP angle or IAC, but 90% of the time, it's going to be a vestibular schwannoma. There are a lot of less common pathologies that may happen at that location, but vestibular schwannomas may have a very varied appearance. That's the most common CP angle and IAC mass in patients who are presenting with sensorineural hearing loss, but there's a lot of differentials we may want to differentiate that from. And we like to see avid enhancement on these lesions on the post-contrasted imaging. And again, we think about all those issues. How much CSF is lateral to the lesion? That's the fundal cap. That may change the surgical approach for these lesions if they're thinking about doing surgery. We try to think about the nerve origin. We look at the cochlear nerve canal, the little canal where the cochlear nerve is going, and we look at the cochlea and the vestibule to be sure they're not involved with the schwannoma. Now, we can have a lot of different appearances to these vestibular schwannomas. We might see cysts within the lesion or around it. We might see hemorrhage. And we want to remember that it's more common to have an atypical appearance of a common entity than it is to have a rare entity at this location. So while we like to see an avidly enhancing and homogeneously enhancing mass within the IAC and the CP angle, we might see little intertumoral cysts within the lesion, like this vestibular schwannoma, especially if you're doing radiation therapy, IMRT, you might see a lot of these intertumoral cysts after IMRT therapy. Or we might see a single large cyst within the lesion itself, like in this case. We might see marginal cysts between the tumor and the brain, like in this vestibular schwannoma, or we might see arachnoid cysts if there's arachnoid septations between the tumor and the brain, as in this case. We might even see T1 shortening, such as hemorrhage within these lesions. This is a pre-contrasted MR. If you look at the nose is dark. Remember that the nose knows. So if the nose is not bright, that might be before contrast. So this is bright signal in this lesion that was hemorrhage within this vestibular schwannoma. Now, we do want to be very wary of very small, tiny IAC enhancing lesions. There is a vestibular plexus, a small vascular plexus that may happen within the IAC. So if we see a very small filling defect and enhancement, we may want to think about the third rules with these lesions. About a third of these lesions just sit there, they don't do anything. About a third grow slowly and a third grow quickly. So if we have a very small lesion, we want to remember that might not actually be a schwannoma. It might be the small vascular plexus. So we might think about doing a follow-up study to ensure no worrisome change. We can sometimes guess the lesion. If it's more posterior and inferior, that might be the inferior vestibular nerve. That's thought to be the most common. If the lesion is posterior and superior, we think about the superior vestibular nerve. And if the lesion is more inferior and anterior, we think about the cochlear nerve. So we can sometimes guess which nerve the schwannomas are arising from. There are some more rare pathologies we might see along the 8th nerve, like metastatic foci that might happen at the CP angle. We can see mets along the nerves like peel mets. We can see mets along the dural surface. We might see mets of the flocculus or tuft of wool, that anterior part of the cerebellum. And we might see mets to the choroid coming out Luschka. So here's dural metastatic disease, avid enhancement all the way along the dural surfaces. We want to try to differentiate that from peel metastatic disease when we might see enhancement along the nerves. The nerves are way too thick in this case. So that might be an example of peel metastatic disease. And to finish up, we have neurosarcoidosis. We know that granulomatous processes like sarcoid and TB love the basal cisterns. So anytime we see nodular enhancement along the basal cisterns, we want to remember neurosarcoid. If that patient has a history of neurosarcoidosis, nodular thick enhancement along the nerves or at the CP angle IC may be secondary to neurosarcoid. So that is a very quick tour through cranial nerves 7 and 8. Remember that complicated anatomy around these nerves, and remember how the surrounding osseous structures of the dense temporal bone may be affected. This is an area where we frequently do both CT and MRI. They're complementary to evolve these complicated structures. So we sometimes do both to evaluate these areas. And I thank you very much for your attention.